Good evening. I'm Stan Mark, Vice Chair of Class Act HR 73, and it's my pleasure to welcome you to this evening's Meet Our Bridges webinar. The presentation will be led by Dr. Ron Dieckmann and Dr. Margie Hogan and is entitled The New Global Health, Kids Care Everywhere at the Crossroads. It is my pleasure to introduce a classmate as well as my former college roommate, Ron Dieckmann, as well as Margie Hogan, the spouse of classmate David Griffin. Ron was educated at Harvard, Stanford Medical School, and the Berkeley School of Public Health. He is a professor emeritus of pediatrics and medicine at University of California, San Francisco, and was the director of pediatric emergency medicine at San Francisco General Hospital for 25 years. Triple board certified in pediatrics, pediatric emergency medicine, and general emergency medicine. Ron has edited 5 first edition medical textbooks, is a frequent speaker at national and international medical conferences, and has received national awards for service to American medical education and training. In 2003, he co-founded PEMSoft, the Pediatric Emergency Medicine Software, a decision support software knowledge system which is now owned by EBSCO, publishing in Ipswich, Massachusetts. His international family travels led him to found Kids Care Everywhere and to donate medical software to under-resourced health systems. Marjorie Hogan is a general pediatrician and adolescent medicine specialist, recently retiring after 40 years of pediatric practice in the Twin Cities. She attended the University of Minnesota, Stanford Medical School, and completed her pediatric residency at the University of Minnesota. Her major areas of expertise and interest include adolescent medicine, general pediatrics, global health, child maltreatment, media and children, and importantly, medical education. Margie has authored several papers, books, and American Academy of Pediatrics policy statements. She has traveled to several countries for volunteer medical projects, including trips with Kids Care Everywhere. She has been the recipient of several chapter awards, including many teaching awards and the Gold-Headed Cane Award for Excellence in Pediatric Medicine. She and David have 4 adult children and 4 grandchildren. I now turn it over to you, Ron and Margie, to make your presentation.
Well, thank you so much, Stan. And I hope that you're seeing my slide deck on your computers. Great. Well, I am broadcasting here from Northern California, and Margie is in New York. So thank all of you for joining us tonight. We have, I think, a lot of good things to talk to you about and also some bad news to share with you. But we know that in the end, we're going to wind up with a positive outlook on what our future may hold. This is our board for Kids Care Everywhere from Berkeley, California. They're all sending their greetings to all of you viewers out there and thanking you for the opportunity to tell our story. Unless you haven't been paying attention, I think you're well aware that we are in a massive domestic crisis in the United States, but we're also in an unbelievable crisis in the global health world. I grabbed this quote from the CEO of Doctors Without Borders from a week or so ago from the New York Times. This organization is one of the most effective global health organizations in the world. They really are on the ground in some of the most difficult spots in the world, and they have a firsthand look of what is really going on in the low-income countries. What Everett says here is something that is very important to start with. We have never seen anything like this massive disruption to global health and humanitarian programs. The risks are catastrophic, especially since people who rely on foreign assistance are already among the most vulnerable in the world. We're going to talk to you tonight about Kids Care Everywhere, our programs, our visions, our values, but we're going to do so in the context of this challenging new development in American global health. Our overall goals for this talk tonight are to let you know who we really are, where we came from. We want to talk about our values, our mission, and our vision, and the impact that we have already had in the low-income world over the last 20 years. Margie is going to take you on a tour of the global sites that we've been working on this year in 2025. And then we're going to turn to a few comments about the crisis and chaos that was precipitated with a withdrawal of USAID money. That is United States Agency for International Development money that's been the longest standing philanthropic program in the world. It was suddenly, abruptly removed 6 months ago and left so many of our partners and everyone in the low-income world in a state of complete chaos. I want to give a shout out to Class Act 73, who have been an incredible partner with us over the last 5 years, and then talk a little bit about fundraising and how we might suggest that you go about looking at this, not just for us, but with many of our nonprofit partners in global health. And then talk just a minute about a call to action for how we are going to mount a counteroffensive to this disastrous development in our world. KCE is fundamentally a 501c3 charity. We are based in Berkeley, and what we do is we donate medical software to doctors in a low resource world. And we have been doing this now for 2 decades. This is our website, and I am going to pause on the slide set in a moment to just show you one of the videos which we created to introduce KCE to the world. The website is a very important instrument for us in our interactions with our donors, with our users, and with the rest of the world. So the website has been a very important part of our organization. And Jenna Meyerson, the wife of another one of our classmates, Roger Meyerson, was a major architect in helping us create this website. So I'd like to now just take a moment and go to the website directly and have you listen to a 1.5-minute video that introduces some of the details of Kids Care Everywhere. So Diana, could you please show us the actual website live?
Mm-hmm. Yep.
Since 2006, Kids Care Everywhere has been on a mission to provide easy access to essential medical knowledge for doctors and other clinicians in the low-income world. We have conducted over 100 projects in 25 different countries, and we have trained more than 10,000 physicians to use a special medical software, primarily on their mobile phones. The software provides them with comprehensive information about current medical science. Our award-winning medical software is called Dieckmann. It is a popular worldwide commercial software that is gifted to us by EBSCO in Boston for free distribution in the low-income world. It is absolutely a phenomenal resource for clinicians and brings to their fingertips at the bedside or in the office a massive amount of medical information that is updated daily. Dieckmann provides users with information not only on their mobile phones, but also on tablets and desktop computers. The information supports every aspect of inpatient and outpatient care and also allows unlimited self-education. Back to the slide set here. And I wanted to mention a few of the metrics which we use and discuss with donors and users about what we have done in the last 20 years. We've been in 27 countries, 3 continents, South America, Africa, and Asia. We've gone on over 96 global missions in those locations and several virtual missions as well that we've turned to recently, as you'll hear from Margie. We've trained over 15,000 doctors. We've donated $11 million in software. And very importantly, we have tracked utilization of our software. And this is one of the most important metrics that we use to actually gauge our success in distributing this knowledge system to our low-income partners around the world. We are getting currently about 12,000 hits on the software that we have donated to doctors a month. Now, if you think about this for a moment, this is a massive amount of medical information that's being transmitted to doctors in the low-income world. This means that 12,000 times a month, a doctor is dialing into our software that we have donated to them with a significant medical question. So we believe this particular metric may be the most important metric for us to follow to be sure that we are doing what we want to do and what we believe we are doing in the low-income world with our partners and our doctor partners. This is the map of the world with all of our sites, except for two. We just recently acquired two more in Uganda and Nigeria, which are right there in sub-Saharan Africa. And they will be with us as well going forward. We're now in 27 countries, as I mentioned. So how did this all start and how do we get to where we are anyway? And this is one of my favorite pictures, which is me, you might be surprised, 20 years ago at Hanoi Children's Hospital. I had just arrived in Hanoi from spending a year in sabbatical in Australia, in Brisbane, Australia. And while I was in Australia, over that year, I had constructed with the help of about 150 doctors, virtually primarily, and with my main software partner in Brisbane, a new form of medical textbook, a new space-age version of a knowledge system for pediatricians, for children. And we tested it in Australia. We began to distribute it commercially worldwide, and it instantly became very successful. On the way home from that sabbatical in Australia, I and my family stopped in Hanoi, and we went to see my good friend, Dr. Nguyen Tu, the man standing behind me there in his practice in Hanoi. And we gave the software to all of his faculty, and they loved it. It was totally fantastic. And we were overwhelmed that everybody who are non-English, primarily English-speaking individuals, could use the software effectively. When I got back to California, I immediately started the process of creating a nonprofit organization so that we could give the software away to colleagues in the low-income world. A few years later, EBSCO, which was a gigantic software company in Ipswich, Massachusetts, acquired our software company. And in the acquisition, we established an agreement that I, through KidsCareEverywhere, could donate the software in any place in the world where there was no commercial interest by EBSCO. And so there we began the next phase of KidsCareEverywhere, where we were actually part of a larger piece of software called Dynamed. And we had basically graduated from the PEMSoft software dealing with pediatrics alone to now Dynamed, which was treating all of the different specialties in all of medicine. In the early phases of our development as a nonprofit organization, we came to look at the holy trio of how we really viewed ourselves and what our mission was. The mission we had was very clear. We wanted to be able to give doctors in the low-income world the same amount of information and the same access to evidence-based information that we had here in the United States and in the Western world. And in fact, whenever I am speaking in any of our sites, the first thing I say to the audiences, to the doctors, is that we are giving you today the same exact piece of software that I am using in San Francisco. There's no more of this crazy business of the past where we would be giving them secondhand textbooks that were 30 years old. We were giving them the same exact access that we have. So that was clearly our mission. Our vision was that there would be no economic barriers to access to the software, and that the doctors like us could access it freely and have a entire library of evidence-based medicine in front of them. And lastly, the exercise that I think was the most important one for us as a young organization was establishing our values as to who we actually are, an organization, and what are we trying to do philosophically. And this included these major values: child and family focus, cultural sensitivity, that this was about them, not about us, that we were doing these missions, empowerment, so that our colleagues in the low-income world would be able to carry on the teaching and use of the software on their own without our endless intervention. We could give them the software, but we know they had to carry it forward. And we felt very strongly that we had to have metrics of impact to prove to ourselves, to our donors, to our users, that we really were making a difference. And lastly, and really most importantly, the value of kindness. That this really overall is the driving virtue that we felt should really characterize our organization. And there have been many times since we began this organization where we have been challenged by many dilemmas, many issues that have come up, but always we go back to this value to make our decision about what to do. What is the kind thing to do for our colleagues in less well resourced countries? Let me tell you a few things about the software itself as it currently stands. With the integration of PEMSOL, my original software tool that many of us created that many years ago, Dynamed is what we call a point of care software tool. That is, we built the software for doctors to be able to use it at the point of care. But we found, interestingly, that so many doctors are using the software at home. And our metrics showed that the utilization is really almost evenly divided between the home and the hospital. Doctors have a lot of clinical questions that they don't know the answers to during the course of day-to-day practice. They go home at night and they look it up on Dynamed. So it's a point of care software tool primarily for mobile phones, but also, as you heard, with tablets and with desktop computers. And recently, as Margie is going to tell you, we have added a powerful and really exciting AI option to our tool that we are giving to as many of our colleagues as we can. Dynamed is an evidence-based scientific knowledge system. It involves about 1,500 experts in the field reviewing all of the topics in detail. The actual database itself, amazingly, is about 75,000 pages. On your mobile phone, when you are at the bedside of a patient and you have Dynamed in your possession, you have approximately 75,000 pages of information to get to. And part of the genius of the tool is being able to provide to the user the ability to get to that information, to that specific clinical question within 10 seconds, because we know that if the user can get there in 10 seconds, they are going to continue to use the software. More than that, it's too long to wait. There's over 11,000 topics, 14,000 drugs. Many hospitals use our software as their primary pharmacy database, and a zillion images and videos. And very, very importantly is the issue of updates. The software is updated approximately 5 times a day. There are continuous updates being done at the server level, and when the user's cell phone gets into Wi-Fi range, there is an automatic upload of information about their utilization, as well as a download of any of the new information from the evidence-based database that we use. This is what the landing page looks like. When a user goes into Dynamed, this is what they see. It's very simplified, but primarily we ask that the users, until they get a little more sophisticated with using the software, to just go right to the search window, right there in the middle. Just ask your clinical question. It can be a disease, it can be a drug, it can be a symptom, a sign, whatever you want, you can put into the search window and then choose your language. English is the primary language, but there's also 30 other languages that allow searching for the topics. Doctors all have mobile phones worldwide, and most doctors can read English, at least medical English, to the extent that they can use the software effectively. So I'm now going to pause and turn the next part of the presentation over to Margie so that she can take you on a tour of some of our current sites. So, Dr. Margie Hogan.
Ron, thank you so much. And I need to mention that Ron and I have been friends for 52 years, along with our spouses, Patty Gates and Dave Griffin, who are also there today with us. So thank you, Ron. It's a pleasure for me to talk to you all tonight about something I'm very passionate about, and that is global health and underserved populations around the world. We have, as Ron said, we've been in many, many sites, and we maintain contact with all of those sites. But we have 4 very exciting places that we're concentrating on for 2025. And these 4 sites have similarities, but also special features that make them very different and exciting. We're maintaining, as Ron said, our partnership focus with our sites. We're not people swooping in to tell them how to do medicine. We're working as peers and partners and giving them the software that we have and that they deserve. We've also formed champions in the latest sites that we've been visiting, where people on the ground in our countries, whether it's Peru or Cambodia or Somalia, can carry on the teaching about Dynamed to others in their institutions and in their country. We think that the champions approach is such a phenomenal strength. And I'm going to talk about 4 sites: Somalia, Ghana, Sub-Saharan Africa, and Cambodia. Diana, next slide, please. I'm going to get a little passionate for a moment here. Somalia has been in the headlines lately, and it's been a very difficult time for those of us in Minnesota, and I think probably around the country, who have grown to know and value our Somali American neighbors deeply. I'm going to get personal for a minute. I've been working with the community for decades, since the first families from Somalia chose to come to Minnesota. We're a very welcoming place for refugees, and families now for decades have found their home in Minnesota. We've had a problem recently with the big fraud case that everyone heard about. That was wrong. It was bad. The Somali people who were involved in that are being held accountable. And the woman who ran the whole procedure was a white Minnesota woman. So go figure. But our Somali citizens are being painted with a broad brush. And it is absolutely heartbreaking to me and to those of us who work with this community. Just to let you know how I got involved, more recently, I'm part of on a board for an organization called Global Health Alliance in Minnesota. It's a nonprofit whose mission is to strengthen healthcare for Somali people in Minnesota, but also in the home country of Somalia that is so important to everybody. And so on this board, a project came up where doctors, nurses, nurse practitioners, midwives were going to go to Somalia, to Puntland, a region of Somalia, and work on teaching and working with the health providers there to reduce infant and maternal mortality, which is among the highest in the world. It's a devastating problem. So I said, maybe I can go along not just as a pediatrician, but I can bring Dynamed to my colleagues in Somalia. So that was my first trip a year ago with a team from Global Health Alliance based in Minnesota to Somalia. And this collaboration is unique, and Ron and I are so proud of it. It's a collaboration between Kids Care Everywhere, Global Health Alliance, the World Health Organization, which we, of course, the United States is no longer part of, just parenthetically, and also with the Somali government. So we've had a wonderful, rich collaboration, and it is ongoing today. In fact, I just got a WhatsApp message from Jonas, who is Global Health Alliance and KCE's person in Somalia, that he's now trained 376 physicians, nurses, nurse practitioners, and other professionals. So this is an ongoing collaboration. What I learned in Somalia was that the healthcare providers there are so bright and so committed and just don't have all the resources that we have in the United States. So it's been a joy to help bring what we have to them. I also learned that nursing is a very important profession in Somalia, and the nurses do so much of the patient care, education, skill building. And so I'll talk a little bit more about that later. As part of our project in Somalia, we are also writing an academic paper on self-efficacy before and after using Dynamed. How do the professionals feel their self-efficacy has grown since using Dynamed? And that paper is being done in collaboration with Kids Care Everywhere, Global Health Alliance, the University of Bosaso in Somalia, and Dr. Ahmed, who is an academic there. The University of Minnesota is also providing guidance on this paper. So stay tuned, that's coming up. Somalia is a country in great need. As you all know, there are concerns about conflicts within the country, and there is an ongoing concern about poverty and about the health statistics that I mentioned earlier. They have also lost over $183 million in USAID funding. Next slide, please, Diana. I wanted to spend just a minute or two talking about the very dire health statistics and outcomes in Somalia. Look at the MD density. We have 150 times as many physicians per the same population group as in Somalia. The maternal, infant, and child mortality rates are devastating, and they are among the highest in the world. When I looked, I think it was about a year ago, only Afghanistan had a higher maternal mortality rate than Somalia. And similarly, a very low life expectancy. Why? There are many reasons. Climate shock. Somalia is ravaged by drought and even by flooding during the year. There is poverty, as I mentioned. There's a fragile infrastructure. So what there is in Somalia is an amazing population of people who are committed to making healthcare more accessible and good for the people who live there. Next slide, please. I want to share just a few. Oh, can we somehow that my picture is being covered up there, Diana? What happened there? Can we get rid of that?
Not sure. Deep covered up by.
Oh, there. I just want to make sure we see all the people on that slide. It doesn't have to be me. I want to share some wonderful pictures from Somalia, starting in the upper left-hand corner and going clockwise. That'd be clockwise. Some of our students at our first training at the WHO headquarters in Garowe, which is in a region of Somalia called Puntland. It's a very safe region. It's a very calm place. It's got wonderful people. And here are some of our first students. The middle slide on the top, we had our students, after they had the Dynamed presentation, come up to the front of the room and present a case using their Dynamed skills. So this is one of our students presenting. The next slide, that's me in the middle, but on either side of me, Jonas, who is our wonderful person on the ground in Somalia. He's our main champion. He's continuing the training. He's brought it in different regions, different institutions, different medical schools. And as I said, we've trained over 375 health professionals. The woman on the other side of me is Ikran Abdullah, who is the creator and director of Global Health Alliance in Minneapolis. And she's a dynamic leader and has the same vision that KCE has for our mission and values. The picture in the middle, I'm holding a beautiful hand crafted with a woven container that can actually hold camel milk. So it's a very special keepsake for me. The picture in the middle on the bottom, when we flew into the airport in Garowe, all the ministers, the government officials were waiting to meet us. And we had tea. We were so beautifully welcomed, but I wanted to share that one picture of all the ministers meeting us. And the final picture is our team getting all the students on Dynamed on their mobile devices. Next slide, please, Diana. Here, I'm going to be brief, but I'm going to be very passionate about this. We now have a new product through EBSCO called Dynamic Health. It's a sibling of Dynamed, but it's aimed at nursing professionals. And I don't think I should say this with Ron on this webinar, but I think I like it better than Dynamed. It's very clear. It's very problem-oriented. It's completely evidence-based. It's updated regularly, very, very current references. And it's used just the same way Dynamed is, with a search bar and all the features. One thing it has that Dynamed doesn't have, and that is it has cultural overviews, looking at all the communities around the world. What things are unique to the Muslim community in Somalia, to the Hindi community in India, to Native communities in Central and South America. It's a wonderful resource, and I think it should be incorporated into Dynamed as well. But that's not my choice. Diana, next slide, please. I'm going to move on to our next active site in 2025, Ghana. And KCE was actually in Ghana well, we know exactly when we were in Ghana. COVID came, and we had to make sort of a quick escape from Ghana at that time. So we have had a presence in the country, but our latest training was virtual. It was a self-directed virtual training, and it's targeting all of the doctors in Ghana. That is the ultimate goal. We have a committee with people from KidsCareEverywhere and a steering committee in Ghana that communicate and work together to make sure this education is continuing through the champions. Again, USAID loss amounted to $156 million for Ghana. That's a huge, huge amount of money. And we have to try to fill that gap in other ways. Next slide, please. Again, the statistics in Ghana, I won't go over it in detail. The health outcomes are not as dire as in Somalia, but are alarming. The MD density is very low. The maternal and infant mortality, unacceptable. And these are ways that we hope access to Dynamed can help in under-resourced countries. And look at these beautiful children. I love these pictures. Next slide, please, Diana. This is a very exciting venture, and it involves Harvard, actually. We are expanding our reach to 7 new sites in sub-Saharan Africa. These sites used to be, they received evidence-based software through Better Evidence, which is a group that works with Harvard's Global Health Development Consortium. And Better Health can no longer provide free UpToDate, which is the software that they provided, to these medical schools. So working in collaboration with them, we are going to bring Dynamed to these institutions. And it's very exciting. First, that it's a collaborative effort. And second, it's really exciting to work in these new places. We're having trainings planned. Champions have already been designated in all these sites. And there's a lot of collaboration going on. And Ron and I and others from KCE are planning a visit to some or all of these sites in the near future. Next slide, please, Diana. Here are the schools. I won't, I know we have to move on, Stan. I'm aware of the time. But Ghana, Kenya, Nigeria, Tanzania, and Uganda are the sites of the 7 medical schools that we will be collaborating with and providing software to. Next slide, please. And finally, our last site to highlight in 2025 is Cambodia. We've been in Cambodia before, and I'm going to just take a moment to say I was there 2 years ago. We both went to Hanoi and Cambodia, and it was a powerful moment for me. I'm a child of the 50s, 60s, and 70s, like many of you are, and being in these places and realizing the horrors that they have been through, partly because of USA involvement, were very hard for me. And meeting the people in both Vietnam and Cambodia and seeing how they reached out to us and wanted us there was really wonderful. It was going to Phnom Penh and seeing the killing fields and seeing tributes to the people that were killed there, being in Hanoi and seeing, reminders of the Vietnam War. It was a big deal for me personally. But we have a great relationship in Cambodia. This year, we did virtual training. There's conflict going on in Cambodia, as many of you know, and it was difficult just to organize the trip. So the trainings were virtual. There were multidisciplinary learners, doctors, nurses, dentists, pharmacists, medical students. And this is the first time that we've been able to integrate AI, Dynamed AI, which is a phenomenal tool, into the trainings. And that's just our first foray into that, and we'll see what happens in the future. Again, USAID monies that are no longer flowing to Cambodia, $260 million. Next slide, please, Diana. And finally, this is the statistics are, again, terrible in terms of health outcomes for under-resourced countries, maternal and child mortality, life expectancy. And again, I think that's what drives us to be involved as volunteers in under-resourced countries. Can we help? Next slide, please. And this is you, Ron. Back to you.
Yes, thank you, Margie, for that fantastic summary of our activities this year in all of these locations. We have in the background of all of our work, crisis all the time. And the withdrawal of the USAID money was only a portion of the actual withdrawal of American resources. Only a few hours after the current president was inaugurated, he already was signing proclamations to remove all kinds of programs, medicines, and monetary support to over 70 low-income countries. The result of that has been gross increases in disease, starvation, and next slide, please. From a calculation that was done and published last week, it is now being calculated that because of American withdrawal of USAID money, 3.1 million deaths are expected in the next 3 years of this administration in children under 5 years of age. Next slide. I want to give you some good news. And the good news is that we have been embraced by Class Act in a way that has really influenced greatly the extent of our distribution of the software, our contacts around the world, and we have had only the best in the way of moral support from Class Act from the very beginning of our association. They have given us contacts. We have gone through many of those contacts to low-income countries, and I am very proud to be part of the board of Class Act, and I immensely appreciate the attention that they had given us, the friendship, the colleagueship that has really helped define us in the last 5 years. Next slide, please. So what is next for us? And I think given all of these travails that we have talked to you about tonight, it really so often comes down to the fact that we need more money. And we need to keep raising the money to keep supporting the sites that we have talked to you about and the ones that we intend to integrate further in the future. Next slide, please. How to do that. For those of you interested in donating to Kids Care Everywhere, this is easily done by going onto our website and clicking the donate button. And when you click on the donate button, this is what you get on the website. First, a choice about how often do you want to donate, or maybe just one time. You may not know how important it is for us to get small donations. We get very few large donations. Almost all of our operating budget in Kids Care Everywhere comes from small donations from interested donors. We have no money that has come to us from USAID or any a governmental source. Next slide, please. And then on the next page on the website, there is a description about how to give money. And I just want to call your attention to the one on the right side in the middle, which some of you may not be aware of yet, but I hope you will be, because qualified charitable distributions are the best way for most people to donate to nonprofit groups. These accounts can be created in any of your financial institutions where you have retirement funds. And when the funds are distributed to qualified 501c3 charities like us, they are not taxable. So this is the critical difference between qualified charitable distributions to nonprofits and donor-advised funds, which is a far more common way for people to donate to nonprofits. And that's a great way to do things. But for those people who do not itemize deductions and fall below the $16,000 ceiling, the better way is to use a qualified charitable distribution, because you will save the entire tax on that donation. Next slide, please. And last, we need to still leave you with some hope. We are not going to stop what we're doing, but we need your help. There are many ways to assist us in the counteroffensive that we have launched to try to make up for some of the depletion of resources taking place in all of the countries that we represent. And this can be in the form of volunteerism in your own communities, as Margie is doing so actively, advocacy at the local level and for individuals in the low-income world, and certainly through cash donations to nonprofit organizations who are actually working on the ground in the low-income world. We have, as a country, been deemed to be a beacon of hope for so long, and I've been proud to be an American for most of my professional career. We are in a new world, a new precarious world, but it is still possible that we can do many things to help compensate for some of the gross losses and that we have seen in all of the countries that we are operating. It is simply not too late to do something good for our colleagues around the world. Thank you very much for your attention, and I hope that we can answer a few questions of yours from the audience.
I don't usually raise my hand, but I just want to say how amazing I think your work is and how honored I am as part of Class Act that we have been able to be helpful to you. So I just, to see this for a period and to see the scope of it, I've heard about it, but to see it, it's a whole different thing. And I'm just so proud of you guys. So I don't have a question. I just wanted to clap my hands.
Thank you.
Thank you.
Therese,
Thank you.
you're muted.
I'm on my phone, which is a little harder for me to negotiate. But I echo what Marion said. This is absolutely incredible work and vital work. And as I put in the chat, I learned earlier this week that to pay for USAID, taxpayers commit to like $24 a year.
Right.
And what do you feel we can be doing to raise awareness even of that fact? Because I mean, that's 2 margaritas at a fancy restaurant, or less than 2 margaritas at a fancy restaurant. And yet, I mean, the statistic you gave of 3.5 or whatever million children dying is just so horrific. And what do you
Yes,
feel that
Therese.
we as a group can be doing to help communicate this?
Yes, Therese, it's a really interesting observation. And I have spoken so many times with friends and associates about these matters, about what has really happened in the in world about the loss of this type of money. And people always say back to me, wow, I cannot believe that really is happening. Why don't more people know about this? And I can only say back is that we as individuals have to assume that responsibility to spread the word about this and to be dedicated to some counteroffensive to actually fill in
I want to
these
raise my
huge,
hand
huge,
right now.
huge gaps that have occurred. We go in to countries and we change medical practice. We transform medical practice when we arrive with the software. And it is now becoming increasingly difficult in every imaginable way to do that. So I feel the only prospect we have
No,
is
just
more dissemination of information about what is going on. Talk to your friends, talk to your congresspeople, talk to your religious leaders, talk to the people that mean something to you about this. It is not only the United States that is feeling the brunt of this craziness that is happening in our political world. It is the whole rest of the world.
Yeah.
Thank you.
Vulnerable
Debbie,
people. Yeah.
yeah. Debbie Nguyen, please. You're muted.
yeah, I know you've talked before about sort of training the trainer, and that when you train someone or give them availability to the software, that trickles down to lots of other people who also have access to it and can be trained. So there's sort of a ripple effect. Can you talk about that?
You're talking probably about
Margie.
our Champions program. And what we have been doing for the last couple of years, Ron, the sites we've gone to in the last couple of years, is designating champions. Either the department head will choose people or people will volunteer. And those people are trained and then get a special training in how to bring the software to other people. So that's the train the trainer method that we've hit upon, the champions. Also, we're focusing on medical students. And I am very, very excited about getting these young people excited. And for their long careers, they'll have access to this and they can pass it on. So I think that's the most effective way to disseminate this around the world.
Yes, I think just to add on to what Margie said, this is the beauty of working with software. Software is so scalable with no cost to us whatsoever, and actually only pennies of cost to the people who donate the software to us. We can disseminate really broadly in that fashion. It is the only future for us to be using champions to really carry on the good work and to pass on the software and to support the use of the software, in the clinical sites. Good question.
Yeah. I'm intrigued by the new software for nurses and nurse practitioners, because there's got to be a lot more nurses and nurse practitioners than doctors. So talk a little bit about the rollout and when you think you'll reach a saturation point.
Oh, Stan, I'm glad you asked that. I do think nurses are the backbone of the healthcare industry.
Mhm.
Not just because my oldest daughter's a nurse, but I've worked for decades with nurses and I know the value. And my experience is in these countries that these are men and women who are so passionate and chose nursing for a reason. And I think, talk about scalable. If we can get nurses to use this software, and I did send it to my daughter, Erin, who's a nurse, and she said, Mom, this is phenomenal. It's usable, it's friendly, it brings in the cultural points that are so important, should be important to everybody. And it's very easy to use. So I think it's going to make a difference. We're working closely with EBSCO, the nurses on the EBSCO staff who design this program and maintain it, and they're hopefully going to be traveling with us too.
Terrific.
Yes, well, let me just mention a phenomenon that exists in the world that we work in that really supports everything that Margie is talking about. In most of the low-income world, doctors leave the country immediately after graduation. In Ethiopia, for example, where we had a very extensive project with the Department of Health, 95% of the doctors graduating from medical school every year immediately leave the country and never practice medicine. So, as Margie said, it's the nurses that become the backbone of the medical systems and so many of these sites that we support. So giving them this nursing software is something we're so excited about because we feel that they are not really good users of the Dynamed software, but the dynamic health software is built for them. It is for their practice. And finally, I think we have something really exciting to give them that's going to be able to support their role in these health systems all through the low-income world.
And a
Wonderful.
shout out to two of my Somali colleagues, Deka and Ikran Abduli, who are on the webinar. Thank you, both of you.
Terrific. We have time for probably one more question if anybody has one. We always like to stay, Cliff.
Hi there. Can you hear me?
Yes, we can.
Okay, good.
Hi, Cliff.
Ron, I jumped on a little late, but did you answer the question about the difference between KidsCareEverywhere's software and just relying on Googling with generic AI?
Well, that's a really, really important and very timely question, Cliff. Absolutely. It's really at the heart of what our future is with AI. And there is a huge difference. Here is the difference. In unvetted sources of medical information that you may go onto for AI, Perplexity, ChatGPT, whatever it may be, the information you're getting may or may not be accurate. In fact, studies looking at unvetted information on AI show a very high error rate in the information they are giving to you because they are looking at the entire expanse of all of the medical literature in the world. The database that is being used with Dynamed and with Dynamic Health, both of the are as information that is being taken from an already vetted database. So all the data within this instrument has already been reviewed by experts in the field so that they are drawing only from information that we know to be truly evidence-based. So the validity of the information. And this is what it's all about in the end. What is the validity of the information you're getting from this? And I think we can safely say that hallucinations, errors that are really common in the AI tools that are out there in common use do not occur in the database of Dynamed and Dynamic Health because of the vetting system that occurs and the really high level of scrutiny that is being used before anything gets published in the websites, looked at by many people. So I think we can safely at this point claim that there is a world of difference in the validity of these two tools when you look at them side by side.
Well, again, thank you, Ron and Margie, for an absolutely wonderful presentation. Thank you for attending and enjoy the rest of your evening. Good
Thank you,
night.
Stan. Thank you.
Thank
Thanks,
everybody.
Stan.